Good afternoon. My name is Jenna Maggard, and I'm the president of the Intermountain chapter of the Association for Professionals in Infection Control and Epidemiology, otherwise known as I-APIC, which is much easier to remember. I'd like to welcome you to the second webinar in our 2012 I-APIC HAI Prevention Learning Network series. This monthly webinar series is offered in partnership with Koalas Health, and we hope that you'll find it both inspiring and useful in your practice. We have planned a series to bring you infection prevention information and expertise that addresses issues you face every day in your patient care world. If you have a subject that you'd like to see addressed in the future, please take some time and pass along those ideas to us. There is contact information on the flyers and on the slide deck handout. I'd like to introduce my colleague, Jennifer Palazzi. She is an APIC board member and Koalas Health consultant. She'll share some brief housekeeping comments and then introduce our dynamic guest speaker. Jennifer?
Thank you, Jenna. I'm Jennifer Palazzi, a quality improvement consultant with Koalas Health, the quality improvement organization for Idaho and Washington. Please allow me to take just a couple of minutes to go over some housekeeping items before we introduce our speaker. I want to thank you all for joining us today. We have well over 100 registrants and many additional listeners sharing those lines. Because of that reason, we will keep all of the lines muted during the presentation, but I do invite you to submit questions or comments in the chat section of your WebEx screen. You'll find that on the right-hand side. And we'll also have a question and answer period at the end of the talk, which may come at the end of the hour, so we may run over a little bit. I want to give a special thank you to Acumentor Health, Oregon's QIO, and also to our neighboring APIC chapters in helping us extend this invitation across Idaho, Oregon, and Washington, and for encouraging participation in this special learning network. RN continuing education credits are available for one contact hour as approved by the California Board of Registered Nursing. Those interested in receiving credit, please complete the sign-in sheet that is included at the tail end of your handouts, and be sure to include your email address and particularly your nursing license number. Completed sign-in sheets can be emailed or faxed to me. A CEU certificate will be emailed to you in about a month. And a recording will be made of the presentation and emailed to you within about a week and also posted on our Intermountain APIC website. Handouts were sent to registrants ahead of time. Please let me know if you're still in need of a copy. You'll find that later on the Intermountain APIC website. And finally, please note that we will have a brief online survey at the close of the presentation, and please take a moment to fill that out so we can continue to improve our offerings and our format. Now, finally, let's focus on today's topic, catheter-associated urinary tract infections, or CAUTI. We are excited to have with us on the line one of CDC's own, Angela Bivens-Antilla, who will pack the next hour full of identifying and reporting CAUTIs accurately. Pay close attention because the audience will have a fun opportunity to participate in answering multiple choice questions during the case study portion of the call. Angela, please lead the way.
Thank you, Jennifer. Good afternoon, everyone. I would like to thank you for inviting me to help you all delve just a little deeper into the use of NHSN by applying some of the case studies to the definitions and criteria. I hope that by the end of this presentation, you will be able to identify the steps necessary to properly identify healthcare-associated infection events, which should be entered into NHSN. So after a brief overview of the CAUTI protocol, we will have about 10 case studies in which we will be using an audience response to allow you all to participate. If for some reason we are unable to get through all of the case studies, I will supply the answers to the conference planners and they can post to the website. But I'm not anticipating any problems with getting through these case studies. So some objectives for this meeting, we are going to review requirements for CAUTI reporting to CMS through NHSN, define CAUTI key terms, review and apply CAUTI criteria and application, define resources and methods for catheter-associated urinary tract infection surveillance. So as you all may already be aware, there are 5 events located under the device-associated module, and CAUTI is just one of the 5 that we're going to be focusing on today. And this slide just gives you a really quick overview of the CMS reporting via NHSN, and you can see for acute care hospitals, January 2012 started the beginning of the mandatory reporting for adult and pediatric ICUs. If we do have folks on the line from long-term acute care hospitals or inpatient rehab facilities, your reporting requirements will begin October 2012. So CAUTI must be included in with your monthly reporting plans for data to be reported on behalf of your hospital to CMS. And with that, you must follow the NHSN CAUTI protocol exactly and report complete and accurate data in a timely manner. And we mean timely manner, we would like for you ideally to get your data into NHSN within 30 days after the reporting month. So you're going to report each CAUTI detected or indicate that no CAUTI occurred for the selected reporting location. And you're also going to report total device days and total patient days for your selected location. This is an example of a screenshot directly out of NHSN, and out of a minimum, this is what, for you acute care hospitals, this is what your monthly reporting plan will look like. So you can see here that you're going to have your location, and this is CLABSI, which we're not discussing today, but you can see here that you're going to select CAUTI. And this is a roadmap to your data, so it's really important that you do complete this monthly reporting plan for us. Just to go over really quickly some key terms. All CAUTIs must be healthcare-associated infections for the purpose of NHSN. So a healthcare-associated infection is a localized or systemic condition resulting from an adverse reaction to the presence of an infectious agent or its toxins that occurs in a patient in a healthcare setting and was not present or incubating at the time of admission unless the infection was related to a previous admission. This is really important, and we're going to talk about this a little bit as we get into the criteria. So the present or incubating at the time of admission is really important since for NHSN reporting, we currently do not have a time period associated with what must be considered healthcare associated, and we'll talk a little bit more about that. Indwelling catheter. NHSN defines an indwelling catheter as a drainage tube that is inserted into the urinary bladder through the urethra, is left in place, and is connected to a closed collection system. Many of us know this as a Foley catheter. It does not include, among others, straight in and out catheters, suprapubic catheters, and nephrostomy tubes. CAUTI is defined as a UTI in a patient who had an indwelling urinary catheter in place at the time of or within 48 hours prior to infection onset. Now, when I say infection onset, that is either the onset of signs and symptoms or the collection of your urine culture, whichever comes first. And you see that I noted on here there's no minimum period of time that the catheter must be in place in order for the UTI to be considered catheter associated. So this is really important for those of you who have Foley catheters or urinary catheters inserted in your emergency department. It's really important for your nurses and your physicians to document if that patient presents to your facility with a UTI on admission. Because if it's not documented, then, and you insert that indwelling urinary device and the patient becomes symptomatic even hours later, according to the current NHSN definitions, that would be reportable as an HAI. So documentation is very, very important. CAUTIs are attributed to inpatient locations at the time of urine collection or symptom onset, whichever comes first. So an exception to this would be the CAUTI develops within 48 hours of transfer from one inpatient location to another in the same facility or in a new facility. The infection will be attributed to that transferring location. So, for example, Mr. Smith is transferred from SICU with a Foley and 36 hours after transfer has a fever of 38.2 degrees Celsius. The next day, a urine culture collected has greater than 100,000 colony-forming units of E. coli. This CAUTI would be attributed back to that SICU. now I'm going to go over the CAUTI criteria and application within NHSN. So there are really two criteria that can be applied for identifying a CAUTI. Symptomatic UTI, also called CUTI, and asymptomatic bacteremic UTI, also called ABUTI. For the symptomatic urinary tract infection, also called CUTI, there are four different criterion groups that a patient could have. And you can see here we've got criteria 1 and criteria 2, A and B. Criteria A pertains to patients who have a catheter at or within 48 hours prior to urine collection or onset of signs and symptoms. And then the criteria B refers to patients who have UTIs but who do not have catheters at or within 48 hours prior to urine collection or onset of signs and symptoms. So for today's session, because we are focusing on CAUTIs and CMS and meeting the CMS reporting requirements, we are going to focus on the criteria A, which are patients that would meet definitions for CAUTI. So within the criteria 1 is culture-based, and criteria 2 is going to be culture plus urinalysis based. And then we also have criteria 3 and 4, and these pertain to your patients equal to or less than 1 year of age. So they're going to have age-specific signs and symptoms. In addition to criteria 3 would be a urine culture greater than 100,000 colony-forming units with no more than 2 species. And then you have criterion 4, which is they have age-specific signs and symptoms in addition to a urine culture that's equal to or greater than 10 to the third, but it has to be less than 10 to the fifth with no more than 2 species and a positive urinalysis. So let's delve in just a little bit deeper. So we're going to start with CUTI 1A. So CUTI 1A is your patient had an indwelling urinary catheter in place at the time of specimen collection and at least one of the following signs or symptoms with no other recognized cause: fever greater than 38 degrees Celsius, suprapubic tenderness, or costovertebral angle pain or tenderness. In addition to at least one of those signs or symptoms, the patient must also have a positive urine culture of greater than 10 to the 5 or 100,000 colony-forming units with no more than 2 species of microorganisms. Now, if you have a patient who had an indwelling urinary catheter removed within the 48 hours prior to specimen collection or onset of signs and symptoms, then that patient has to have at least one of the following signs or symptoms. And you'll notice here, in addition to the suprapubic tenderness or costovertebral pain, the patient could also have urgency, frequency, and dysuria. So this is specific to patients who do not have a urinary device in place at the time of symptom onset or culture collection. In addition to one of the symptoms, the patient would need to have the positive urine culture of greater than 10 to the 5 with no more than 2 species of microorganisms. So that's 1A, CUTI 1A. And then you have CUTI 2A. And these, again, are for patients who do have an indwelling urinary catheter in place at the time of specimen collection and at least one of the following signs or symptoms, which are the same: suprapubic tenderness or costovertebral angle pain or tenderness, and a positive urinalysis is demonstrated by at least one of the following findings. So they would need to have a positive dipstick for leukocyte esterase and or nitrite, pyuria, or microorganisms seen on a gram stain of unspun urine. In addition to the positive urinalysis, the patient would need to have a urine culture of greater than or equal to 10 to the third, but less than 10 to the fifth, with no more than 2 species. And then if the patient if the patient previously had a urinary catheter removed within the 48 hours prior to specimen collection or symptom onset, the signs and symptoms have the additional 3: urgency, frequency, and dysuria. And then the remainder of that criteria is the same as above. Okay, so criteria 2, I like to call this urinalysis and culture-based, and then criteria 1 is strictly culture-based in addition to your symptoms. So those are the 2 criteria that you will predominantly use for your CMS reporting. And here is a flow diagram that I just wanted to show. I'm not going to go through this, but I find that this can make following this protocol easier for you. And this is in our manual as well as in your handout. And then I want to touch on asymptomatic bacteremic UTI. We also call this ABUTI. There's sometimes confusion around this particular criteria. So this is for patients with or without an indwelling urinary catheter in place that has no signs or symptoms. So they do not have a fever, no urgency, frequency, no suprapubic tenderness, no crossovertebral pain. For your patients equal to or less than 1 year of age, they will also have no fever, no hypothermia, no apnea, no bradycardia, no dysuria, no lethargy, and no vomiting. Okay, so in addition to the patient having no signs or symptoms, the patient is going to have a positive urine culture of greater than 10 to the 5, or 100,000 colony-forming units, with no more than 2 species of uropathogen microorganisms. That's very important to meet this criteria. In addition to the positive urine culture with the uropathogen microorganism, the patient must also have a positive blood culture with at least 1 matching uropathogen microorganism to that urine culture. So or at least 2 matching blood cultures drawn on separate occasions if that matching pathogen happens to be a common skin contaminant. Now, I've got listed here, I'm not going to read to you, but a list of the uropathogen microorganisms, and this list is also on our website under the resource page. And I also just want to mention here that for CMS reporting, to meet those reporting requirements, you do have to follow ABUTI and report ABUTI, but you only have to report it in patients who have a urinary device in place or had one in place within 48 hours prior to that specimen collection or onset of signs and symptoms. And then just a little note at the bottom, all ABUTIs will also have a secondary bloodstream infection because you need that positive blood culture to meet this protocol. So surveillance consistency is a must. Our criteria is designed to look at a population at risk. We identify patients meeting that criteria. It's really important for our users to consistently apply the criteria because this ensures the comparability of data and protects your facilities and others, and it strengthens the validity of the data. And I will point out, clinical and surveillance definitions may not always agree, as you're going to see as we get into these case studies. So very quickly, I want to go through entering CAUTI events into NHSN. So these are going to be what forms your numerator. So you'll notice that anytime you log into NHSN and you're going to enter an event, the top section of any of your forms is going to be the data collection area, and there are 4 required fields in that patient demographic area. Facility ID, which should automatically populate when you log in, patient ID, gender, and date of birth. Anything with a red asterisk is required. And then if you move down to the event information, you're going to enter your event type as a urinary tract infection, and then you're going to enter the date of the event. And the date is going to be the date of signs and symptoms onset, or the date that the diagnosing urine specimen was collected, whichever comes first. And then you're going to enter what is post-procedure. This is an optional field, but I like to mention it because if you do select post-procedure, you would only mark yes if the event occurred after an NHSN-defined procedure, but before discharge from your facility. So if the patient had an NHSN-operative procedure, you could mark yes. And then MDRO surveillance. This is a required field, and you're only going to mark yes in this field if the pathogen that you're reporting in with this CAUTI event is being followed for infection surveillance in the MDRO CDI module in that particular location. So if you're not currently using the MDRO CDI module for NHSN reporting, you would always select no, even if the pathogens match. So you would select yes if the pathogens match, and you're reporting into the MDRO CDI module for that particular location as part of your monthly reporting plan. And then moving down to, where are we here? To date admitted to facility, that is required, and that is the date admitted to the inpatient location. And then location, right above that, that is also a required data field, and that is you're going to enter the location of the patient to which you are assigning that UTI. So, for example, the transfer rule would apply here. If the patient develops a UTI 48 hours prior to transfer from a location, you would indicate that transferring location, not the current location of the patient. So that is going to be the location that you're assigning the UTI. And then moving down to risk factors. Urinary catheter, you're going to select in place, it was removed within 48 hours, or neither. It's not in place nor within 48 hours. Location of device insertion, this is an optional data field, but I think it's important because it allows you to internally track patient locations where these catheters are being inserted. And this is particularly important for your outpatient locations, such as your emergency department and your operations or your surgical suite. If you wanted to track infections that occur after indwelling devices are inserted in one of those two areas. And then date of device insertion is also an optional field. If you would like to enter it, you can. And then moving down to event details, specific events, you're going to select, in this case we've got CAUTI, symptomatic UTI selected, and then you're going to select the specific criteria that you use to meet that definition. It's really important that everything you select meets the NHSN criteria, or else you're going to get an error at the end of your data entry, and it will not allow you to save the record. Secondary bloodstream infection, this is a required data field, and this is if the patient also had a confirmed bloodstream and related documented healthcare-associated UTI. So remember, all of your duties will have a secondary bloodstream associated. But there may be also cases where you have a CAUTI and the patient also has a secondary BSI with a matching pathogen to your urine culture. For secondary BSI, for UTI, at least one organism from the positive urine culture must match an organism in the blood culture. And the antibiograms of these isolates do not necessarily have to match. So an example would be if a patient with a urinary catheter grows E. coli in her urine and in her blood, the CAUTI is reported with a secondary BSI. And then the pathogen would be E. coli. So just to point out, you can have a secondary bloodstream infection, but you cannot have a secondary CAUTI for NHSN reporting. And then moving down to the event details, you're going to mark if the patient died. And this is a data field that is not necessarily required at the time that you're entering the data. So, for example, if the patient is still in your hospital, you could leave that blank, and NHSN would still allow you to save the record as incomplete, but you would have to go back and mark that as a yes or no. And then if the patient did die, you would have to indicate if the UTI contributed to that death. So if the UTI caused the death or exacerbated an existing condition which led to that death, you would mark yes. And then you would move down to your pathogens identified, and you can enter up to 3 pathogens here. And if you have multiple pathogens, you're going to enter the pathogen judged to be the most important cause of the infection as number 1, the next most important cause is number 2, and so forth. And then collecting your summary data for your denominator. So for all locations, it's really important that you count at the same time every day. You want to collect the number of patients on that particular unit, as well as the number of patients with an indwelling urinary catheter. Okay, so we are going to begin our case studies now. And like Jennifer had mentioned, this is audience response. So as we move through the case studies, you will have an opportunity to select an answer. and you're going to have 20 seconds to make that selection. To help you, I recommend that if you printed out your handout, you should have a Table 1 included with your handouts, and that is the CAUTI definitions, and that will help you as we move through these case studies. Okay, so some ground rules we like to cover for case studies. The purpose of these studies are for training on the use of definitions as they exist today. I already mentioned that the surveillance and the clinical picture may not always align, and then to optimize data reliability and quality. So the examples in these case studies highlight some of the common errors or difficult issues that our users experience. So beginning with case 1, we have a 50-year-old patient with end-stage pancreatic cancer with liver and bone mets, admitted to hospital with advanced directive for constant care and antibiotics only. Only catheter, peripheral IV, and nasal cannula inserted. On day 4, patient is febrile to 38 degrees Celsius and has suprapubic tenderness. IV interfillin started after urine obtained for culture. On day 5, patient has difficulty breathing. The chest X-ray shows infiltrate of the left lung base. On day 6, urine culture results 10 to the 5 colony-forming units of E. coli. On day 7, the white blood cell is 3,400. Patchy infiltrates in both lung bases. Continued episodes of dyspnea, rales noted in left lower lobe. On day 11, the patient expired. So does this patient have a UTI? And if so, what type? So give just a moment, and we're going to have the polling box will pop up on your screen. Okay, you have 20 seconds starting now. So if you answered yes, CAUTI criteria 1A, you are correct. So the patient did have an indwelling urinary catheter in place at the time of collection. The patient did have at least one of the following signs or symptoms, and that was the suprapubic tenderness. And then the patient also had a positive urine culture. So I see here that 35% of you did get this correct. And keep in mind that the patient did have a fever of 38 degrees Celsius, but the requirement to meet for NHSN is greater than 38 degrees Celsius, so we cannot use that to meet the criteria. Very good. Okay, so case 2, 66-year-old patient in the ICU with a Foley catheter, surgical procedure exploratory lab, patient noted to be febrile with 38.9 and complained of diffuse abdominal pain. White blood cell increased to 19,000. He had cloudy, foul-smelling urine, and urinalysis showed 2+ protein, positive nitrite, 2+ leukocyte esterase, white blood cell count, negative, 3+ bacteria, culture was 10,000, colony-forming units of E. coli, the abdominal pain, same localized to the surgical area. Is this a UTI? If so, what type? Okay, so if you said yes, CAUTI criterion 2A, so that's number 3, you are correct. So the patient did have an indwelling urinary catheter in place. The patient did have a fever of greater than 38 degrees Celsius. The patient did have a positive urinalysis, leukocyte esterase, and nitrite. The patient also had pyuria, and then the patient had a urine culture of 10 to the 3rd, greater or equal to 10 to the 3rd, but less than 10 to the 5. So we have, so 34% of you did get that correct. Good job. Okay, so case 3. We have an 84-year-old patient is hospitalized with GI bleed. On day 3, the patient has an indwelling catheter in place and no signs or symptoms of infection. On day 9, the patient becomes unresponsive, is intubated, and the CDC shows a white blood cell count of 15,000. Patient has a temperature of 38 degrees Celsius. The patient is tan cultured. Blood culture and urine culture both grow Streptococcus pyogenes with a urine culture of greater than 10 to the 5. is this a UTI? If so, what type? So as you're answering this, keep in mind that the patient had a matching blood and urine culture. Also think about that temperature of it was 38 degrees Celsius. And the patient had no other signs or symptoms of infection. So the answer to this is, yes, the patient does have a UTI and a booty, so an asymptomatic bacteremic UTI. So the patient had no signs or symptoms, and the fever was not greater than 38 degrees Celsius. The patient did have a positive blood culture with at least one uropathogen matching to the urine culture. Now, what if this organism in both cultures had been micrococcus? Is this a UTI? So no, this would not be considered an booty because the micrococcus is not a uropathogen. So remember, to meet the criteria for a booty, it would have to be a uropathogen. So very good, 36% of you got this correct. You guys are good because 20 seconds is not a lot of time to answer these questions. So I have to say I'm impressed with not only your quick response time, but the accuracy of your answers. Very good. So this is just a list of the uropathogens here. And again, we have this on our resource page on the website. Moving on to case 4. We have a 3-week-old infant born at 27 weeks gestation, umbilical catheter in place, the heart rate of 100, respiratory rate of 32, and core temperature ranges between 37.8 to 36.2 degrees Celsius. The baby is lethargic. A straight cath urine yields greater than 100,000 colony-forming units of Enterococcus faecium. One blood culture collected the same day also positive for Enterococcus faecium. Susceptibilities do match. So is this a UTI? And if so, what type? So I'm going to answer this one, and we're going to do the polling on the next. So, yes, this would be considered a UTI, but is this a CAUTI, and if so, what type? Okay, so no, this is not a CAUTI because the patient did not have an indwelling device in place. They were using a straight cath on this patient. And remember, a straight in and out catheter is not considered indwelling. But I also want to just go back really quick because all of these questions were answered. So is this a UTI? Yes, it certainly is a UTI. If so, what type? So if you look at your criteria, you'll see that this will be SUDI 3. And then it's just a CAUTI. No, it's not a CAUTI. So in this case, if you're only reporting catheter-associated UTIs, this particular patient would not be reported into CMS. Okay, so does this patient have a Class C? So keep in mind that your blood culture and your urine culture matched. So the answer to this is kind of a tricky one, is no, the patient does not have a Class C. But the patient does have a secondary BSI. So if you look at that, although there is no CAUTI, there is a UTI present, and the blood cultures are related to an infection at another site, so is related to the UTI. So this would be reported as a UTI with a secondary BSI. So this was a little bit tricky because this case was so long. And over WebEx, it makes it just a little bit difficult to follow. But you guys still did pretty good. 35% of you answered no. Okay, let's move on to case 5. So we have a 48-year-old male involved in a motorcycle accident, closed head injury, multiple fractures. The patient was taken to the operating room for an open reduction internal fixation and evacuation of subdural hematoma. A Foley catheter and left subclavian catheter placed in the emergency department, Patient remains on a ventilator placed in the OR. Lungs are clear bilaterally. 6 days post-op, temp 99.8 Fahrenheit, bronchi and left lung base, chest X-ray shows possible infiltrate and atelectasis in this area. Urine draining, clear yellow by Foley. Patient remains ventilated, sputum increased white. Post-op date 7, temp 100.3 Fahrenheit, vent setting stable, no change in sputum production. Post-op date 8, temp 101.9, lung sounds clear, chest X-ray clear. Patient on a ventilator with Foley in central line, pan culture sent, empiric antibiotic treatment begun. Post-op day 9, urine culture 100,000, a Pseudomonas aeruginosa, sputum Pseudomonas aeruginosa, blood culture no growth. Physical assessment normal, no patient response to suprapubic or crossovertebral angle palpation. Okay? So does this patient have a UTI? If so, what type? So if you said yes, number 4, SUDI 1A, you are correct. Okay, so we've got about 30% of you answered that correctly. So yes, the patient does have a SUDI 1A because the patient did have a fever and positive urine culture of greater than or equal to 100,000 with one pathogen. So what if the patient had been afebrile but had an elevated white blood cell count for which they think the cultures as reported? Would the patient have a UTI then? Okay, so if you answered no, then you are correct. So 38% answered no. And the reason is because the fever was the patient's only symptom. And if you remember, the patient did not have a positive blood culture. So we could not count this as an booty because you would need the matching blood culture with a uropathogen. So the patient does not meet any of the criteria without a fever. And just to reiterate, surveillance definitions work better in some patient populations than others. It's really important if you're seeing a lot of patients that seem to have UTIs and they're being treated for UTIs, but you cannot find the documentation of the suprapubic pain or the crossovertebral. It's really important that you provide education to your nurses, your physicians on the importance of documentation so that you're not under-reporting your UTI events in your hospital. And again, the clinical diagnosis may differ from the surveillance determination. And irregardless of this, you must follow the NHSN definitions so that apples to apples can be compared with other like facilities. Okay, case 6. 73-year-old patient in neurosurgical ICU admitted 7 days ago following a cerebral vascular accident. Ventilated, subclavian catheter and Foley catheter in place with admission. Patient reacts only to painful stimuli. Then on 9-2, white blood cell slightly elevated at 12,000, temp 37.4, urine cloudy, lungs clear. On 9-3, white blood cell increased to 15.8, temperature 37.6 degrees Celsius, breath sounds slightly coarse, minimal clear sputum, urine unchanged, blood endotracheal and urine cultures collected, no suprapubic or CVA pain noted. On 9-4, blood and endotracheal cultures, no growth. Urine is positive for 100,000 ECHM. Does this patient have a UTI? And if so, what? Okay. So if you answered no, you are correct. So number 4. Because there are no urinary symptoms, nor fever greater than 38 degrees Celsius, nor matching urine culture, nor blood culture matching urine culture, there is no UTI considered here. So great, 42% of you got that one right. So let's go to, so what if the patient's temperature was 38 degrees, 0.1, and the patient also met criteria for pneumonia, including a bronchoalveolar lavage for ECHM? Would that patient have a UTI then? Considered a non-specific symptom and may be due to more than one cause at a time. So what that means is a patient can have a pneumonia as well as a UTI, And because you are not going to know which of those infectious processes are causing the fever, you could use fever to meet both criteria for NHSN reporting. So in this case, the patient would have a SUDI 1A that with an indwelling catheter present, a fever, and a urine culture greater than 100,000. Good job. Case 7. 816, 4-year-old girl admitted following an MVA, taken to the OR for open reduction and internal fixation, multiple upper and lower extremity fractures. Admitted to pediatric surgical care with Foley catheter draining yellow urine. Right femur contraction. IV in right antecubital vein. 818, fully removed, patient voiding without problems, a febrile, taking clear liquid diet and beginning oral pain medication, DM in the AM, using incentive spirometer. 819, tolerating solid diet, IV converted to saline lock, voiding without trouble on bedpan. 820, patient has a slight cough, a clear phlegm, DM in the AM. 821, temp 37.5, cough continues, phlegm slightly yellow, using incentive spirometer. Open reduction, incisions and traction sites clean, vasopressin to traction site. 822, patient requesting bedpan frequently, crying with urination, temperature 37.9, cough unchanged, straight calf urine, culture collected, urine cloudy, UA positive for leukocyte esterase, nitrates negative, 5 WBC by HPS, spun urine. Later that evening, gram stain of urine showed centigram negative rods, empiric, vasopressin was ordered. Case 7, 823, urine culture positive, 50,000 colony-forming units of E. coli. Does this patient have a UTI? Did you answer 4? Yes, for SUDI 2B, you were correct. The patient had a positive dipstick for leukocyte esterase. The patient had positive urine culture greater than 10 to the 3rd, but less than 10 to the 5. Microorganisms were seen on the gram stain. Very good, so 30%. Case 8. 68-year-old female admitted to 6 East from the OR, status post left Capro, Foley draining pink urine, hacking nurse reports difficulty with Foley placement, bold suction to knee via stab wound draining small amount of blood drainage, IV in left forearm, site without redness and dressing dry. Patient controlled analgesia via pump. 9-2, drain removed. Patient up to bathroom with help of physical therapist. Fully removed, IV continues, taking full liquids for lunch. Patient is a febrile. 9-3, patient to physical therapy, complains of burning with urination and urgency. Suprapubic pain upon palpation. Temperature 37.8 degrees Celsius, urine collected and sent for culture and UA, positive for 10 plus WBCs by high power field of unspun urine, positive leukocyte esterase, empiric antibiotics begun. And 9-4, urine culture positive for greater than 100,000 of staph epidermidis. Does this patient have a UTI attributable to 6 East? So if you answered 1 to yes, the patient has a SUDI 1A attributable to 6 East, you are correct. So the patient does have a SUDI 1A, however, since the OR is not a bedded location where you collect denominator days, no device-associated events can be attributed to that location. One thing I just want to note here, if you do want to track, again, those locations, you could utilize the custom event feature of NHSN to monitor such sites. So in this case, it would be attributed to the inpatient location, which would be 6 East. So the patient did have urgency, dysuria, suprapubic tenderness, and a positive urine culture greater than 10 to the 5. Good job. Okay, case 9. How many indwelling catheter days do we have? So if we do our catheter day count at 12 noon. So the correct answer here, even my answer here is incorrect. So the correct answer here is E, 2. So if we're looking at catheter day count at 12 noon, we looked at patient in bed 101, day 2, indwelling Foley, okay? And then we go down and we do patient in bed 106, day 5, indwelling Foley. So we would not include the bedpan, we would not include the voiding, and the reason we did not include bed 104 is because the patient's admission was not until 2 p.m. So we did our catheter day count at 12 noon. Okay? Do one more. So how many indwelling catheter days do we have here? If we do our catheter day count at 11 p.m. included, patient in bed 102 does have an indwelling Foley, so that patient counts. This patient's voiding. 104 is incontinent. 105 is suprapubic direct drainage, but suprapubic does not count. 106 has an indwelling Foley, but the patient was discharged at 4 p.m., and since we did our count at 11 p.m., this patient will be excluded, and then the last patient is voiding. So the answer to this one is 1, and that would be 102, Dallas. Okay, great job. And before we open the lines for questions, I just want to point out the resources that we have available for NHSN users. I have the link at the bottom of the page here, but you can see we just have a vast amount of resources. So we've got this page, and then here in the NHSN patient safety component, we actually just recently updated this after I submitted my slides. So this was updated in February of 2012. And just some things that I think are important. Chapter 7 is the CAUTI protocol, which I think is really important. And then we have Chapter 14 is table of instructions. And this actually walks you through completing the data fields when you are entering your numerator and denominator data in NHSN. So Chapter 14 is a very, very good chapter. Chapter 16 is key terms. Chapter 17 is criteria for specific infections. And then moving on, these are your NHSN forms. So you have the forms for your urinary tract infection, your denominator data, and so forth. And then also we just released an operational guidance document for acute care hospitals to report CAUTIs to CMS, and here is the link for that. It's a really good document. And that's all. So I think we're ready. Jennifer, if you guys want to open it up for some questions.
Thank you, Angela. That was great. Operator, we can start taking questions from folks that's in their offices, if you want to give them instructions.
Yes, ma'am. Ladies and gentlemen,
while we're getting a lineup of those questions, Angela, we did have a question on the chat box. Someone wondering if they can use this slide deck to do training with their infection prevention folks.
Absolutely. So it is a government document, so you are welcome to use this document. We cannot provide the PowerPoint presentation because you can't edit our document. So you could use the information. You would just have to redo this into a PowerPoint format because we can only provide the PDF version.
While we're seeing if there's additional questions, again, this is Jennifer. I wanted to mention, as you see on the slide here, that this is a monthly series. Next month, we actually have Angela's colleague, Catherine Allen Gritson, who will be doing a very similar presentation on surgical site infections. And so please join us for that on Wednesday, March 14th. And then going into April, we will be focusing on Clostridium difficile. And we will have Ruth Jericho with us. And Angela, if you don't mind going to the next slide, which would be the final slide, this is just some information for everyone. Contact information if you want to get in touch with the CDC and NHSN folks, or even Angela, go ahead and use that email address you see there. We have contact information for their quality improvement organizations in Idaho, Washington, and Oregon, and also our Intermountain I-APIC host. Trish Heath is our education lead, and there's some contact information there. Again, I know a lot of you will be getting off the line here in a minute. Please do fill out the brief survey that pops up as you close. Do we have any questions, operator?
Thank you. I just had a question about the scenario, and I forget which number it was, where the patient had a fever of greater than 38, the positive urine culture, and the positive symptoms, signs and symptoms, and diagnosis of pneumonia. And I'm wondering why that
urine wouldn't be excluded because there are signs and symptoms of infection in another location?
So the urine would not be excluded for that because the pneumonia is considered separate. And remember, a CAUTI cannot be secondary to another infection. So the secondary to, so that phrase, and actually we're planning on taking that phrase out of some of our protocol because it does bring much confusion. So related to an infection at another site. So what that is really referring to is symptoms. So let's say that you had a patient who had an abdominal hysterectomy, and that patient was readmitted to your hospital with abdominal pain. So you could not use the suprapubic tenderness in that situation to meet the CAUTI protocol because that would be a sign or symptom that could potentially be as a result of something going on at another site. Now, fever is different. You can use fever to meet more than one infection. So in that case with pneumonia, the patient had a positive urine culture, and the patient also had a fever. So even though the fever could have been related to the pneumonia, it could have also been related to that CAUTI. So you just don't know. So we allow it to be used to meet both criteria.
And so that just fever is used in that way then?
Right, correct.
Okay, thank you.
You're welcome.
I wanted to, while we're pulling up our next question, Angela, we had a question on the chat. How far apart can a fever and a positive urine culture be linked?
That is a great question, and we get that question a lot. And unfortunately, we do not have a black and white answer for that. That is, we leave some room there for clinical judgment. If it's a day or two apart, then it makes sense that it's probably related. If it's more than 2 days, you're going to want to question if that's really related to a potential UTI. But again, there's no black and white guidance in our manual for that.
Suprapubic placed, but also have an indwelling catheter for a few days. Do we count those in our denominators or not?
You do not count the suprapubic, but you would count the indwelling.
So if they developed, if they met criteria, like 2 days after the suprapubic was placed, and they still had the indwelling catheter, then we would count that as a CAUTI, right?
Potentially, if now, so the suprapubic, so you're saying they had a suprapubic, but it's not being utilized?
No, they come in and they're going to have one placed. So for a couple of days after surgery, they have both in place.
Okay. Yeah, so that's a gray area, Janet. But yes, if the patient does meet the CAUTI criteria, then it would be reportable as a CAUTI, unless you had a good case for one, maybe it was the infection was related to that suprapubic site. Now, suprapubic is not included in the CAUTI definition, but it is included as an ALDI, which, not to confuse you even more, but we had ALDI infections in our CAUTI protocol chapter. We just recently moved that out to chapter 17. So if you do report other UTIs or if you report ALDIs, then you would report that as an ALDI. But the difference is with ALDIs doesn't allow for a positive urine culture. So if you have a positive urine culture, then it would be reported as a CAUTI, just because you could not say it meets the criteria for an ALDI. Does that make sense?
Yes, it does.
So if it met the criteria for an ALDI, you could throw it into that bucket. If it doesn't meet that criteria, but it meets the CAUTI, then you would throw it in that bucket.
Okay, thanks a lot, Angela.
And you're welcome. And just to let you guys know, also, we are here, we have a clinical team, a small clinical team, but we do have a clinical team here. And we're here to do these types of presentations for you, but we also have the NHSN mailbox that we man. And if you have cases that are a gray area to you or you're unsure, if you would send us the details of the case, we would be more than happy to help you troubleshoot through that case and give you an answer.
Okay, Angela, this is Jennifer, and I'm going to go ahead and pick a question off of the chat line here. What if you have a patient who is UA and culture positive with the catheter but does not have documented symptoms urgency until the catheter is removed 24 hours later.
So that would be fine, yes. So again, we don't have specific time-related criteria, but clinically that does make sense. So you could definitely use that. Within a day or two, it would be clinically reasonable.
And while we're waiting for any other questions, Angela, this is Jennifer, and I was one of those lucky few people who got to be in Atlanta last week for the NHSN training. And so did I hear that the definitions are going under review right now? Anything you want to share about what might be on the horizon for folks?
We are currently looking at our definitions, and I'm hesitant about telling you guys what's coming up because I just don't want to confuse you, but I'm going to give you just a little bit of insight. We're looking at the time period, so in the future it will not be this year at all, but potentially in 2013 you may see a time period associated with the device being in place, as well as the time period that the patient has to be in the hospital before it's not considered present on admission. Currently, there is no time period associated. One other thing I will mention, if any of you have read the updated CAUTI protocol that just came out a couple weeks ago, there's a statement in there in regards to catheters that are irrigated, being excluded from the numerator and the denominator. We had much discussion, Jennifer knows, at the I-APIC or at the conference last week in Atlanta, and I will tell you that we are currently undergoing a literature review to really look at the risks, the benefits of including those patients in with our denominator and numerator. So for now, if you have patients that are receiving continuous irrigation to their Foley catheters, then those patients will be should be excluded from both denominator and numerator. If the patient receives a flush because, let's say that the catheter is clotted, then those patients you will include in with both denominator and numerator. So we will be sending some more guidance out as soon as we finish our literature review. So over the next several months, you should see something.
Jennifer? Thank you. I thought of another question. I saw in the update where it said that if you have a mixed gram result along with a single result from the same culture, that would be excluded because there would be more than two pathogens present. Is that the correct understanding of that statement?
Correct. So if you get a result that, let's say that you get as pathogens, you get greater than 100 of E. coli plus a mixed contaminant or mixed result, then you could probably assume that that mix is going to be more than one, and so that would exclude that result from being included into the CAUTI criteria. If you get one positive culture that is greater than 100 of mixed, then you may want to follow up with your lab to see if they can narrow that down and quantify that for you, because if it's more than two, it would be excluded. But if it is just two, then you could use that result.
Thank you.
We did have a question earlier on around, will prevention strategies be addressed in this WebEx? And I was able to answer that myself because of the time limitation, we're really focusing on how to identify correctly label UTIs and CAUTIs and such. But I wanted to let everybody know that there are various groups that are working on prevention strategies, your quality improvement organizations in your state, the newly identified hospital engagement networks, some of your hospital associations. So make sure if you need some assistance in tackling prevention strategies, look to some of these groups, get in touch with them because they may have things in place to help you out.
There are no further questions.
All right. Well, I want to thank everybody for sharing their time with us today, especially Angela. Thank you so much. You made this great content-packed presentation dynamic for us. Thank you for allowing us to participate with the polling piece.
My pleasure.
And if you all think of questions after you get off the line, please feel free to forward them my way. Again, there's contact information in the slide deck and on the flyers. We'll be happy to hear from you. I'll send out a recording of this presentation to Angela and also to all the registrants. And be sure to fill out your information for those continuing education units if you're an RN. Angela, again, thank you. And we'll go ahead and sign off for today. We hope to see you all next month.